It's my great pleasure to introduce Dr. Juan Pablo Kaski, who is the leader of the Inherited Cardiovascular Disease Group from Gauche, and he will present to us a differential diagnosis of heart muscle disease in children and adolescents. Juan, please. Thank you.
And thank you to all of you guys for coming back after coffee. So we've heard some really fascinating talks throughout the day today about the etiology, different etiologies of heart muscle disease, and in particular this afternoon with a focus on amyloidosis and sarcoid, about diseases that are almost exclusively adult conditions. And so what I hope to be able to do over the next 20 minutes or so is convince you that pediatric cardiomyopathies are just as interesting, if not more. So I'm surprised this slide hasn't come up before. This is Michael Davis's classic slide from the cardiomyopathy conferences, just demonstrating that the classification of cardiomyopathies is really based upon the morphology of the heart muscle features. We've seen this slide before. Today, again, highlighting the fact that the cardiomyopathies are classified according to their underlying etiology: familial genetic causes, non-familial non-genetic causes. Jerry spoke earlier on today about the different etiologies of dilated cardiomyopathy, and he touched on many of these causes. This is really a non-exhaustive list of the conditions that can cause left ventricular dilatation in the pediatric population. So we've heard a lot about myocarditis earlier on today, metabolic conditions that Giuseppe spoke very elegantly about earlier on today, and neuromuscular disease that Professor Duboc highlighted. So I'm not really going to focus on this condition at all. This extremely busy and illegible slide actually is my talk. So this is the differential diagnosis of cardiomyopathies. But I'm not going to stop there, so I'll try and make it a little bit more interesting. So I think of all the cardiomyopathies, perhaps hypertrophic cardiomyopathy is the one where the different etiological backgrounds and genetic basis is best described. And certainly in the pediatric population, that's the case. We know that in adults and in adolescents, most cases of hypertrophic cardiomyopathy are caused by sarcomere protein gene mutations. And there's a small group of about 5 or 10% of cases that are caused by additional, mainly genetic, but some non-genetic causes. And we've heard about many of these already today. These so-called secondary causes of left ventricular hypertrophy are perhaps more important in the pediatric population. So there are a number of metabolic conditions, inborn errors of metabolism, many of which we've already heard about from Giuseppe earlier on, a number of malformation syndromes, particularly Noonan syndrome and other disorders of the RAS-MAP kinase pathway, and also a number of neuromuscular disorders, in particular Friedreich's ataxia. And it was felt until relatively recently, actually, that these causes were the most important causes of hypertrophic cardiomyopathy in children. However, registry data from North America, but also from Australia, show that although these causes are perhaps a little bit more important than in the adult population, they still represent a relatively small proportion of all cases of hypertrophic cardiomyopathy in children. This is even in infancy, so these are children diagnosed with hypertrophic cardiomyopathy in the first year of life. And in fact, we know that in the pediatric population, the cause of hypertrophic cardiomyopathy is almost always sarcomere protein gene mutations. So these are data from our own institution in pre-adolescent children. But it is important to pick up these additional secondary causes. This was alluded to earlier on with amyloidosis, and there's a similar situation for some of these rare pediatric forms of cardiomyopathy. So we know that particularly in infancy, individuals with inborn errors of metabolism or malformation syndromes have a substantially poorer prognosis than children with what is known in these registries as idiopathic hypertrophic cardiomyopathy, as a primarily sarcomeric hypertrophic cardiomyopathies. But also for some of these conditions, particularly some of the metabolic conditions, but increasingly some of the syndromic conditions, there may be specific treatments, potentially curative treatments. So it's very important to pick these conditions up. One of the themes of today has been the red flag approach that Professor Apezzi and other colleagues have highlighted. And I think this is particularly important in the pediatric population for hypertrophic cardiomyopathy. And so it's this group here that we're really focusing on. Are there any clinical features that can help us to identify a specific disease that then leads to further specialized tests and the multidisciplinary approach, as we've heard already? This is the diagnostic approach to the infant with hypertrophic cardiomyopathy, but really it follows the same pattern. So we're looking for clinical clues in the family history, on the ECG and on the echo. We're looking for dysmorphic features that might give us a clue as to the presence of underlying specific dysmorphology syndromes, and the number of neuromuscular symptoms and metabolic tests that we've already heard about. We've seen this in several forms already today. The inheritance pattern of the cardiomyopathy can give us a very important clue to the underlying etiology in pediatric cardiomyopathies. So autosomal recessive disease is seen in Friedreich's ataxia, in some nuclear mitochondrial mutations, and in the glycogen storage disorders, and in dilated cardiomyopathy and the desminopathies, for example. X-linked inheritance can be seen particularly in Danon syndrome and in some of the Emery-Dreifuss muscular dystrophies, as well as the dystrophinopathies, as we've already heard. And matrilineal inheritance is typical of mitochondrial DNA mutations. There are some red flags on the ECG as well. We've seen these already. So a short PR interval, ventricular pre-excitation, very typical in patients with AMP kinase disease, but also in mitochondrial disease and a number of storage disorders. Conduction disease, which is rare in sarcomeric hypertrophic cardiomyopathy, particularly in children, is much more common in mitochondrial disease, again, AMP kinase disease and Danos disease. An extreme superior QRS axis is something that's very typical in patients with Noonan syndrome. And the presence of extreme hypertrophy or voltage criteria for hypertrophy is very, very common in some of the storage disorders. And similarly with the echo. So presence of biventricular hypertrophy, typical in storage disorders, in Noonan syndrome. A concentric pattern of LVH is what we see in Friedreich's ataxia, but also some of the storage disorders. And extreme left ventricular hypertrophy is almost pathognomonic for storage disorders in children. And the presence of development of an end-stage disease is something that we don't see very commonly at all in pediatric hypertrophic cardiomyopathy, but when we see it, it's very, very typical of mitochondrial disease and some of the infantile forms of storage disorders. So what I thought I'd do actually is, rather than just talk at you and give you lists and tables, I thought I'd go through some cases, some real-life cases, to see how this approach works in the clinic in real life. So this is the first patient. So the proband, or the person that we're seeing, is this child here. So he was diagnosed with hypertrophic cardiomyopathy at the age of 6. He has a pigmentary retinopathy and a degree of developmental delay. And this is the pedigree. You can see there are a number of different individuals. You probably can't read what all these things say. But many individuals in the family are affected. The inheritance is purely from females to males. And if you really read the small print, there's a little bit of ophthalmological disease here. There are some individuals who have died suddenly with hypertrophic cardiomyopathy, but also individuals who are given a diagnosis of dilated cardiomyopathy and die of end-stage disease or require transplantation. This is the ECG. So very tall voltages, but the key feature here is the presence of ventricular pre-excitation. And this is the echocardiogram. So there's gross left ventricular hypertrophy with a concentric pattern, a concentric distribution. We've also seen this boy's cousins. And this boy here is the most recent addition to the family, a 3-month-old, diagnosed at the age of 3 months with hypertrophic cardiomyopathy because of family screening. And over the last few months has demonstrated a delay in standing and walking, and there's evidence now of a potential skeletal myopathy. And this is his echocardiogram at a few months of age. So again, severe concentric left ventricular hypertrophy in the infantile period. So there are a number of red flags in this case, in this family. There's very early onset, particularly in males. There's ventricular pre-excitation. There's biventricular hypertrophy. There's a history of developmental delay. There's clear X-linked inheritance from the pedigree. And there are additional features, a skeletal myopathy, pigmentary retinopathy. This is Danon's disease. So Giuseppe mentioned this earlier on. This is a mutation in the LAMP2 gene causing Danon's disease. There are very few other things that this could be with that picture. Here's another case, a 3-month-old, the only child of consanguineous parents, presents with respiratory distress and gross hepatosplenomegaly. That's his ECG. This ECG can only be one thing. But these are gross voltages here. Also a very short PR interval, but really huge voltages. We don't tend to pay too much attention to the voltages in paediatric practice because often tall, thin teenagers have very tall voltage anyway, but not to this degree. This is grossly pathological. And this is the echocardiogram. So this is extreme biventricular hypertrophy, no cavity at all. Extreme right ventricular hypertrophy as well as concentric left ventricular hypertrophy. So again, a number of red flags here. Parental consanguinity suggesting an autosomal recessive pattern of inheritance, a short PR interval, extreme biventricular hypertrophy, hepatosplenomegaly. Again, this can only be one thing. This is Pompei's disease, infantile Pompei's disease. Another case. So 4-week-old, first child of non-consanguineous parents, again presenting in the neonatal period with respiratory distress and tachypnea. Was noted on the routine examination to have undescended testes and also renal abnormalities and has a chest wall abnormality. And that's his ECG. At first glance, this doesn't look like a particularly abnormal ECG, but there's one key feature here that's very unusual in this age group, and that's the presence of a left superior QRS axis. So it's subtle, but it's definitely there. That's the echocardiogram. So there's biventricular hypertrophy, in this case with a concentric distribution. You can't see the mitral valve very clearly here, but it's not normal. But this child also has a pulmonary valve dysplasia with pulmonary valve stenosis. So again, a number of red flags here. Superior QRS axis, biventricular hypertrophy, valvulopathy, and a number of dysmorphic features which can be very subtle in the early neonatal period, but then can become more obvious as the child grows. And this is Noonan syndrome, or a disorder of the RAS-MAP kinase pathway. Here's a 12-year-old with a history of recurrent falls and clumsiness, mild scoliosis, no cardiac symptoms, but this echocardiogram. So it's concentric left ventricular hypertrophy, no left ventricular outflow tract obstruction. This is Friedreich's ataxia. And sometimes the cardiac features manifest before the ataxia does, but that's rare. So usually it's the other way around. Here's another case. I've got lots of cases. So this is the child we're seeing in clinic. So he presents, because of the family history, but primarily he presents to the neuromuscular team with toe walking and muscle weakness. His mother has a diagnosis of a muscular dystrophy, as do 2 of his male cousins. There's another cousin here who has a muscular dystrophy, but also is said to have a severe cardiomyopathy. There are 2 individuals here who died suddenly from hypertrophic cardiomyopathy at a very young age. This lady also has a muscular dystrophy, and her son is affected with muscle weakness as well. This is the boy's ECG at the age of 12, so very poor pictures. He was quite overweight. But this is probably within normal limits at this stage. 3 years later, though, there's very significant concentric left ventricular hypertrophy, so very rapid progression of hypertrophy. And that's the ECG with abnormal repolarization at all voltages. So again, a number of red flags in this case. There's a muscular dystrophy in the family. There's an excellent dominant inheritance here. There's very rapid progression of hypertrophic cardiomyopathy, but also a family history of sudden cardiac death in males. This is an FHL1 mutation. This is a form of X-linked Emery-Traphus muscular dystrophy. Again, very, very few other things that this history all put together could be. It's my last case, Perry, I promise. So this is a 7-year-old who's referred for cardiac screening because of a family history of hypertrophic cardiomyopathy on the mother's side of the family. He has reduced exercise capacity and leg pain and fatigue. That's the ECG, which doesn't really project very well at all, but what's very clear is that there's evidence of ventricular pre-excitation. And that's the echocardiogram. There's concentric left ventricular hypertrophy, It's difficult to tell here, but that cavity is a little bit larger than you'd expect it to be in someone this age with left ventricular hypertrophy. So let's look at the family. So he has a brother who's 5, younger, has concentric left ventricular hypertrophy, has a reduced ejection fraction and very similar symptoms. Mum has a diagnosis of dilated cardiomyopathy, of hypertrophic cardiomyopathy made 6 months ago, but there's also left ventricular dilatation with impaired systolic function. Further out in the family, an uncle with mild left ventricular hypertrophy, asymptomatic, another uncle with mild LVH at the age of 20, no symptoms, an aunt who died at the age of 26 with concentric left ventricular hypertrophy but died of heart failure, having had an ICD prior to that. It's a very long, very big family. They're an Irish family. Left ventricular hypertrophy, renal disease, Wolff-Parkinson-White syndrome, more LVH. And it grows. Renal failure, sudden cardiac death further out in the family, left ventricular hypertrophy. And so on. So a number of red flags here. There's a diagnosis in childhood. There's clear matrilineal inheritance. I can go back to the family tree, but it's every child of the mother who's affected has the diagnosis. There's a family history of end-stage hypertrophic cardiomyopathy, often in very young individuals. There's a history of renal disease. In our patient, a child, there's left ventricular hypertrophy, but also left ventricular dilatation. His brother has impaired systolic function, a very unusual combination. And there's also ventricular pre-excitation. So again, putting all of this together, this is the mitochondrial cytopathy. This is a point mutation in mitochondrial DNA. So this is mitochondrial disease. So just before I finish, there are a couple of pitfalls that I think are perhaps particularly relevant to the paediatric population. Professor Rapetti's already alluded to some of these. Here's an infant who presents with failure to thrive, breathlessness and poor feeding and sweating, typical paediatric heart failure symptoms, and this is the echocardiogram. This is left ventricular dilatation, thin-walled left ventricle, grossly impaired systolic function, a bit of mitral regurgitation. This is dilated cardiomyopathy, right? Or is it? So in fact, this is an anomalous left coronary artery from the pulmonary artery, Al Kappa. And you can see that there. This is the coronary artery with reversal flow reversal coming into the pulmonary artery. You can see it beautifully in this echo picture here. So this is coronary flow, reverse coronary flow going into the pulmonary artery. And very typical features on the ECG with ischemic changes and pathological Q waves in the lateral leads. This isn't just a pediatric diagnosis. So this is from an 18-year-old girl who presented actually with a cardiac arrest. But this is the CT scan showing the exact same pathology. In her case with huge collateralization from the right coronary artery. But this is Al Kappa in a teenager. Very rare, but it does happen. And Professor Rapetti's already alluded to this. So this is a 12-year-old with palpitations. This is the echocardiogram. Lots of ventricular ectopy. Is this ARVC? In fact, it isn't. It's an ASD. This is a secundum ASD. It's a shunt. And as Professor Rapetti has also demonstrated, it's not just ASDs that can do this. Partial anomalous pulmonary venous drainage can also cause right ventricular dilatation, which is not ARVC. It's possibly a phenocopy of ARVC. But it's one of the things that people need to think about when they encounter these sorts of presentations. So I'm actually going to stop there, Perry. So there's a bit of time for further questions, if that's all right.
Thank you very much, Ryan.